Okay, next, please. And I'm going to let Dr. Patton to take over here.
That's great. Thank you, Brenda. So I'm Doug Patton. I am the campus dean for MCG's regional clinical campus based in Albany, but we cover all of Southwest Georgia. I'm delighted to have been a part of this program from its beginning, and I'm grateful to the Georgia Cancer Center and the Department of Dermatology for continuing to support this effort beyond the original grant period. And so we hope to continue to make these sessions available to you on a regular basis and to provide meaningful content to you, which helps you, the providers who are out there on the front line, provide better care for your patients and to actually become competent enough and confident enough to feel good about managing some of the things that you felt previously like you weren't able to do. So we're going to do as we usually do. We're going to roll out some of the basic information about the TeleECHO platform and what we do here. So again, this whole effort is designed to improve knowledge, and in this case, a specific type of telemedicine related to teledermoscopy and teledermatology, and to improve the confidence and the use of this at a local level using these distance learning techniques so that we can help address the dermatologic health disparities faced by people living in the rural areas around Georgia. Next slide, please. We are recording these sessions as we always do, and as was announced earlier, and you're consenting to being recorded by participating. Just as a reminder, this is not a consultation. This is an educational thing. So it is very important that we be mindful of that, not to mention any PHI in any of our discussions. There will be information in the final slide and also in the chat about continuing education credits for both CME and CNE. And of course, you can either put your questions in the chat, or after the meeting, you can always email to teledermatology@augusta.edu. Next slide, please. We do collect data, and this is part of our obligation is to share with you that we do collect data about that. That includes information from your registration, who's participating, questions and answers that are deemed particularly pertinent to us as we develop future educational opportunities. And occasionally we may even have poll responses that we'll collect. We do share this information with Project ECHO as we're part of their international/global network of teleeducation, and so that they can help understand what the reach of their mode of education is, but also to be able to share best practices globally to help extend the importance of this. Next slide, please. Just some general Zoom reminders. We do this all the time. I've been doing this for a long time now, and I still forget to unmute myself. So let's remember to keep our microphones mute when we're not speaking and unmute ourselves when we do. The easiest way to get a question addressed is to type it into the chat, but you can also raise your electronic hand. As soon as we recognize it, at an appropriate time, we'll recognize you, ask you to unmute your microphone, introduce yourself, and then ask your question. If you can, if your bandwidth will allow you to, please leave your camera on at all times so that we can have a visual cue as to who's actually still in the meeting and who's not. Gallery view is available so you can see as many people as possible. Again, use the chat or email Kenza, who's helping us with the technical aspects of this meeting. Email her at kmamouni@augusta.edu. But again, the chat is our easiest way to communicate. Next slide, please. So it's my privilege at this point to introduce, excuse me, Dr. Renee Copeland, who is a PGY2 dermatology resident at MCG at Augusta University. She had on her running shoes to get over from the VA to get here today in time, hopefully for this presentation, and hope she's had a chance to catch her breath. And if we are ready for that, Dr. Copeland, I'll ask you to just take over and run from here.
Thank you, Dr. Patton. Hi, everyone. I'm Renee. I'm a second year resident, first year dermatology resident. And today I will be presenting on hidradenitis suppurativa. You can go to the next slide. So overview of this presentation is today we will discuss the clinical presentation of hidradenitis suppurativa and the importance of early intervention to prevent progression. We'll review the pathophysiology and how it guides treatment, and then we'll discuss the various treatment options, highlighting the need for a multidisciplinary team. And then on the right, you'll see, I'll make sure to include plenty of pictures so that you can identify the more indolent versions of HS and then also the more severe version. So you can see the one on the top is a little bit more subtle than the one on the bottom. You can progress to the next slide. So what is hidradenitis suppurativa, otherwise known as HS? It is an inflammatory skin condition which typically presents as boils or tunnels of the skin folds beginning at puberty. As you can see on this picture on the right, you can see kind of the really common areas where you'll see HS flare. If it's left untreated, it can lead to significant disfiguring scarring, contractures, and rarely it can also cause really aggressive squamous cell carcinomas. It is associated with a number of comorbidities, including obesity, diabetes, tobacco use disorder, depression, acne, and PCOS. It occurs in up to 1% of the population and most commonly affects women and Black individuals. Next slide. So the pathophysiology, they've been studying this for a while and they've found 3 key things that contribute to the pathophysiology of HS. The first being genetics. When patients come in, we typically ask them if they have a family history of HS, and that is present in about 30 to 50% of patients. There's also this pro-inflammatory pathways with cytokines, which will later guide treatment options. So typically this is the IL-17s and the TNF alphas. And then additionally, there's the disruption of the microbiome. And the disruption of the microbiome is important to emphasize that it's not an infection that's causing the HS. It is specifically a disruption of the microbiome. When you swab a lot of HS lesions, you're going to get either negative cultures or you're going to get cultures that just grow normal skin bacteria, which again points to that idea that it's not an infection. It is more just a disruption of the microbiome that we need to work to address. Next slide. So there's 3 different stages of HS. There's stage 1, and these are the patients that come in with very few abscesses. They don't have scarring or sinus tracts. And then in stage 2, you have recurrent abscesses, typically in the same locations, with sinus tracts and scarring with normal skin in between. And then stage 3, you'll have these multiple connected sinus tracts and abscesses with extensive scarring in these areas. Next slide. There is a strong stigma with HS, which is why it can take a long time for diagnosis. Patients often have a strong sense of shame or fear speaking up about their condition, and they often express concerns that they feel unclean or unsanitary due to poor hygiene that's causing these boils and nodules. And then this in turn leads to increased depression and social anxiety in HS patients. Next slide. So with that, early diagnosis is really important. There's an average delay in diagnosis of 7 years, and patients will have typically seen a physician more than 5 times prior to being diagnosed. If a patient presents to you in your clinic with, boils or in the emergency department or something like that, a screening question to ask is, have you had boils in the past 6 months in the axilla, groin, genitals, etc.? I went to an HS Academy a few months ago, and they had mentioned this is a question you could ask in nearly every patient that has acne, because a lot of times, like I said in the last slide, patients aren't going to speak up about something like this because they're embarrassed to talk about it. And then criteria for diagnosis is typical lesions. Patients will have nodules, abscesses, and tunnels that are recurrent, and they're typically greater than 2 lesions over 6 months. And then they just occur in the typical locations, intertriginous areas. And then in these photos on the right, you can just see more examples. The photo on the bottom is actually a patient we saw in clinic last week. She has HS, and we have It's actually well controlled in the axilla, but in her groin, she continues to have these recurrent flares. So we were able to get a picture of just a typical nodule that she'll have. Next slide. So early treatment is necessary to prevent irreversible damage, like I had discussed before, the contractures and really bad scarring. So treatment consists of lifestyle modifications, topical therapies, oral therapies, surgical treatment, and then biologics. Next slide. Lifestyle modifications are used because they reduce disease activity and progression. The number one thing that we see in our patients with HS is that they're smokers. So we highly recommend that patients that come in with HS stop smoking. If you're here or in the area, WellStart MCG's tobacco cessation program is really helpful because it allows the patient to come in and it doesn't, when we tell them to stop smoking, they're not having to go home and do it by themselves. They'll have a team working with them to help them stop smoking. Additionally, we counsel patients on weight loss and dietary supplementation. We recommend an anti-inflammatory diet just to help decrease the inflammation that is associated with HS. And we recognize that exercise can be really difficult with painful lesions. So just working to get the disease under control can be really important to help patients be able to exercise to in turn lose weight. And then finally, one of the supplements that we recommend patients use is zinc, 90 to 100 milligrams daily, and it must be used in combination with copper, which is 2 to 3 milligrams daily. The reason for that is if you just take zinc, patients can end up with a copper deficiency, so we just try to supplement the two together when we do it. And then another lifestyle modification is laser hair removal. It's typically an out-of-pocket cost, but it actually is covered by TRICARE. So if you have a TRICARE patient, laser hair removal might be something to consider for them. Next slide. Topical therapies. So these are we use these in all patients with HS, but it's most effective in early stage 1. So those patients that come in with just, a solitary or very few boils or abscesses will prescribe these topical therapies. First, we prescribe a benzoyl peroxide wash of 5 or 10%, or a chlorhexidine wash. You let it sit for 5 minutes before rinsing off. And then we also prescribe clindamycin, and this must be prescribed in combination with antibacterial soap, which are discussed above, to prevent antibiotic resistance. And we recommend using the gels or the swabs. Gels are most approved by insurance, but the swabs are really well tolerated by patients. They like them because they're just like really easy wipes to use in these areas. Next slide. And this just emphasizes the need to use benzoyl peroxide with clindamycin. Don't give clindamycin by itself. Next slide. So our oral therapies, the first set of oral therapies that we'll talk about are hormonal therapies. And this is important because HS is associated with hormonal changes. As you can see in the picture on the right, you can see a lot of HS nodules on this patient's neck, but it's surrounded by a line of acanthosis nigricans, which shows kind of the insulin resistant component of HS. We also have patients that flare around their cycle. So a lot of the therapies that we give are aimed at hormonal therapies. So in females will do spironolactone. We typically start at 100 milligrams daily, but doses can range between 7,500 to even 300 milligrams daily for females. And males, we do a similar treatment, but we do finasteride, 1.25 to 5 milligrams daily. And then we also will prescribe OCPs to help with the hormonal component of HS. And then we look at anti-inflammatory therapies. These are typically done in flares, but then we can give metformin, which is used as more of a maintenance therapy that you can give at all times. But for flares, we'll do doxycycline 100 milligrams twice daily for up to 12 weeks. And then prednisone will do flares for up to 2 weeks. Next slide. And then the biologic therapies. This is typically done once you have kind of failed all those other therapies that we discussed previously. But the aim of the biologic therapies is to reduce the inflammation associated with hidradenitis suppurativa. There's 2 indications. It's patients with mild to moderate disease who fail kind of those first-line therapies we discussed previously. And it's first-line in those who just come in with really extensive HS. So there's TNF-alpha inhibitors, adalimumab. which is FDA approved for HS. And then certolizumab is not FDA approved, but it is safe in pregnancy. So you have a patient that is flaring with really significant disease in pregnancy. We can give them certolizumab just to help with that HS flares in pregnancy. And then there's 2 IL-17 inhibitors that are approved. There's secukinumab and bimekizumab. Bimekizumab is the newest one. It was just approved just a few months ago, but they have really good results in reducing the inflammation and the number of new nodules and abscesses that appear for patients. Next slide. And then if you have a patient that is flaring, a lot of flares can occur due to a lot of different things. It's stress, excessive perspiration, which happens a lot down here in the South. It gets super hot in the summer. They can flare due to their menses or weight gain. And patients have found a lot of different options to be helpful. This includes warm compresses because it helps those sinuses to drain. Epsom salt baths just help to relieve kind of the pain associated. Vicks vapor rub, dilute bleach baths, and then diclofenac gel or lidocaine gel or patches. And then oral pain control options include acetaminophen 1,000 milligrams up to 3 times a day, ibuprofen 600 milligrams up to 3 times a day, or you can alternate the 2 regimens to help decrease that pain. And then on the right, you can just see different types of flares. You can have patients that have these draining sinuses, or the patient on the bottom likely has a lot deeper sinus tracts that you can kind of feel under the skin if you were feeling. Next slide. And then finally, we have our surgical therapies. There's surgical therapies that we would use in acute lesions, so incision and drainage. This relieves symptoms of fluctuant abscesses. However, it has a really high recurrence rate. And then you have de-roofing. This is typically done by a Mohs surgeon in an ambulatory practice, so the patient would be awake for the procedure. And in this case, the surgeon would remove the skin overlying the sinus tract and leave the base intact and allow normal skin to grow in by second intent. And this just achieves local disease control. And then in more chronic lesions, you can do a wide excision, and this excises all the diseased skin and leaves all the way to the layer of the disease-free skin and the subcutaneous tissue, and this has the lowest recurrence rate. So if you remember that patient that I showed earlier with that one boil in her groin, she had done wide excision of both of her axilla, so she hasn't had recurrence of the disease in her axilla. Next slide. And I just want to emphasize that treatment of patients with HS is an interdisciplinary approach. First and foremost, it takes the patient being willing to undergo all the treatment options. It's the patient being willing to stop smoking, being willing to every day use, the washes and the soaps that we recommend, and then being willing to move on and try other treatment options. So it really takes a lot of different physicians and other members of the medical team, including dermatology, surgery, endocrinology to manage like the hormonal imbalances, psychiatry because of the significant burden of mental health that HS has on patients. The PCP is very important, as well as patients' OBGYNs, because they might be the first people to recognize HS in a patient, as well as nutritionists and dietitians to just help our patients live out like the best lives that they can and reduce eating inflammatory foods that may contribute to their HS. Next slide. So in summary, HS is a chronic inflammatory skin disease, often misdiagnosed and leading to delays in treatment. HS can occur as a result of genetics, inflammation, and microbiome disruption, but it's really important to emphasize that it's not an infection, it can't spread to other people, and really eliminate that stigma that patients might feel about having HS and that they're unclean or dirty. And we have various treatment options that have a role in reducing disease activity and progression, and multidisciplinary care is key for optimizing outcomes and improving quality of life for HS patients. Next slide. And so these are resources for patients, but there's also resources for healthcare providers as well on these. So the HS Foundation, this is a national organization that just helps provide resources for patients with HS, but also resources for healthcare providers with HS. So that's a good resource to have. There's Shine a Light on HS. This is a resource for patients, and it will just have a lot of things to discuss treatment options and allow patients to know, what's going on in their care, as well as these other organizations, HS Connect, Hope for HS. And then the HS Foundation has an app called HS Papaya app, and this just allows patients to track their symptoms. So they can figure out when they flare the most or that sort of thing, and you can kind of figure out what triggers are for their flares. So these are just a lot of resources for patients. The next slide. And that's it.
Thank you, Dr. Copeland. That's incredibly in-depth and also super interesting. As somebody who practiced general surgery in a rural community where we didn't necessarily have access to dermatological services for all of our patients, I can tell you that a lot of these cases wound up in my office. Fortunately, we have a lot of new therapeutic interventions now that we didn't have when I started practice back in the 80s. So it's good to hear that we've been able to make some progress in that direction. I'm curious if we have any participants who might have questions for Dr. Copeland, and I don't see anything in
There
the
is a question in the chat, like if there is any similar symptoms with inflammatory bowel disease and hidradenitis, or is something related?
There actually is an association with inflammatory bowel disease and HS. And one thing that you can mistake the two for is just kind of Crohn's lesions in the perianal region. You can, the differential would be HS versus kind of Crohn's lesions.
Good to know.
Yeah, and I will say that you have to be careful with the IL-17 drugs, which are just approved now for HS and are wonderful. They're contraindicated if you have inflammatory bowel disease. So that's something you want to clarify before you use those medications. I would like to just make one other comment, and that was a great presentation. Smoking is a big issue, but I'll tell you, vaping is a big issue right now. And our people who are vaping, it clearly flares their HS. And if you look at the algorithm among some of the societies, like the British Society of Dermatology, the first thing they do is tell you to stop smoking and stop vaping. And so I've had patients benefit just from stopping vaping. Smoking and tobacco vaping are really toxic to hair follicles. And this is a hair follicle issue. So we try to make sure that patients understand they have to participate in getting well.
Yeah, that's good to know. Most of the patients mention, I stopped smoking, but I'm vaping.
Yes.
That's not better.
Exactly.
Well, from a marketing perspective, they were very effective at helping people believe, or at least give them affirmation if they thought that vaping was better than smoking and also a pathway to stop smoking and using altogether. We know that that's not true at this point. We do have another question from Edwin, and it's when considering the cost of the patient, which of the mentioned pharmacological options tend to be the most cost-effective initial options for patients? I like the way you're thinking.
I would say overall it's, our topical options, the benzoyl peroxide, clindamycin, those are pretty easily accessible for patients. And then we do see in patients that don't have really severe disease, like a long-term course of metformin and spironolactone can be really effective, and they're not expensive medications because they've been around for a long time. Sorry, guys.
Yeah, I would agree with that too. I mean, spironolactone is a great drug for this. With acne recently, they've shown that spironolactone does just as well as doxycycline after a 4-month course. And now that we're trying to not mess up the microbiome and change it, dermatologists are really trying to avoid doxycycline and other antibiotics, and especially in HS, which we know we don't cure, but we treat chronically. And spironolactone is a great long-term therapy for this condition. You can't take it if you're pregnant, so that is the one thing. But you can't do a lot of things if you're pregnant. So that would be the only time in a female where we wouldn't use it. But I agree. I think spironolactone and metformin are both good drugs for this condition. We have many of our patients on both, especially our overweight patients on metformin.
I think something very important here is to emphasize the lifestyle together with the oral or topical treatment. I don't know what your experience, Dr. David, Dr. Renee, how compliant are the patients like when you suggest lifestyle change? And
All right, and we have another question from Jenny. Are intralesional corticosteroids to be a part of the treatment plan for a patient? Is this common practice for patients with painful lesions? So intralesional corticosteroids, what's their role?
Yes, I realized I left that off of the flare plan, but we have plenty of patients that call the clinic on the day of a flare, and yes, they come in and get intralesional steroid injections into the lesions. The one patient's photo that I had earlier in the presentation, that's what she had come in for, was to get some intralesional steroid injections. And typically we just do them on these patients like every few months when they have a flare. But ideally we would be able to get them on biologics if they're having recurrent flares like this and get their disease under control.
Great, thank you for that. And I hate to be the one to poke this skunk, and maybe it's not even a relevant question, but in terms of management of weight and things like that, is there a role for GLP-1s in obese patients who are suffering from hidradenitis suppurativa?
Definitely. I think we've seen a lot of patients come through that are on the GLP-1s and their disease is getting better with GLP-1s with the weight loss, so they have less lesions and stuff like that with the weight loss. So I think there definitely is a role of GLP-1s, especially in the future with HS.
Okay. And we haven't uncovered any complications from the use of GLP-1s in patients that already have HS that we know of? I'm guessing.
Yeah, relatively young population, and we do have patients on it. We will sometimes send people to their primary care doctor to consider starting it. We don't start it, but it's been beneficial for multiple of my patients. Losing weight and not smoking are the two most wonderful things you can do if you have HS, and we know we have to help those people. So we do send them to nutrition, and these medications probably are going to be used more often for this purpose.
Two of the hardest things to do is to get people to lose weight, exercise more, and then stop using tobacco or vaping in this case. So
yeah.
All right, that's great. Well, we may have some time at the end if there are other questions and things like that. But at this point, I don't want to be guilty of not leaving plenty enough time for our case presentation. And so at this point, I'd like to introduce to you Cameron Liss, who's a third-year medical student at MCG. And Cameron is going to talk to us. Well, there we go. It's the importance of looking close. We'll just leave it to that. And also want to mention just a word of appreciation to Dr. Rabinovitz again for always being there to help us, especially with our student resident level presentations. So Cameron, we'll turn it over to you.
Yes, thank you, Dr. Patton and Dr. Copeland. Great presentation. So good afternoon. Today's clinical case presentations are on the importance of looking close. So I'm Cameron Liss, a third-year medical student at the Medical College of Georgia. And again, I'd like to thank Dr. Rabinovitz for his help in preparing this lecture, and to the TeleDerm and Rural Georgia program for putting on these sessions. So for our first case, we have a 30-year-old man who developed an acute progressive pruritic eruption of his right back of a few days' duration. He presented to his primary care physician for evaluation and management. Would any caregivers in the audience like to make a diagnosis? And how would you manage the patient? Or any students? So I guess.
Can't see everybody, but if you want to raise your hand, if you want to chime in, and it could be a question even at this point. Anyone? Okay, no takers on that, Cameron, go ahead.
All good. All right. So, yeah, a little giveaway there. Well, the differential of the physicians who saw the patient were herpes zoster, a fixed drug eruption, and a bite of some sort. So the patient was started on Valtrex and as well as antibiotics for presumed superinfected herpes zoster. And when there was no improvement, he was referred to dermatology clinic for evaluation. So if you focus on this slight erosion with scale crust of this large pinkish red plaque, and you place a dermatoscope on the scale crust, this is what you would see. A tick bite with the tick, and it resembled the dog tick. I think that was on the pathology in the next slide. Yes. So for the next case, this is a 66-year-old man who we have, who was evaluated for a dome-shaped smooth papule surrounded by an area of inflammation of the left lower leg. The patient reported a history of hiking in the woods, and upon examination with the dermatoscope.
Norma, can you move to the next slide? There we go, thank you.
Thank you. Yes, so upon examination with the dermatoscope, we saw it resembled a dark black leg suggested of the black leg deer tick, Ioxides scapularis. So that one also, yeah, it's on the next slide. And as you can see, the deer tick was quite engorged and deeply embedded in the skin. And rather than attempt to remove it with forceps, a punch 5 was performed to remove the entire tick. In addition, the patient was given doxycycline as prophylaxis. And the histology was consistent with the tick. And here one could see the remnants of the embedded tick fragments. So for our next case, this patient was seen by Dr. Buchanan in her clinic. So clinically, a dome-shaped brown-black nodule, and the dermoscopy features included multiple colors, white shiny structures, and polymorphous vessels. When biopsied, an invasive melanoma measuring 4.22 millimeters and ulcerated. So this is a high-risk patient for metastatic disease and needs to be followed carefully in clinic. And then some months later, at a follow-up visit, he developed a dark crusted papule with surrounding erythema. Would anybody like to venture a diagnosis here? So, okay, so with the dermatoscope, we saw a lone star tick. So what are the types of ticks that you see in Georgia? So according to the Georgia Department of Public Health, the most common human biting ticks in the state are the lone star tick, the American dog tick, and the black-legged deer tick. So the lone star tick gets its name for a silvery white spot located on the female's back. These ticks attack humans more frequently than any other tick species in the eastern and southeastern states. It's a vector for many dangerous diseases, including tularemia, Heartland virus, and the Bourbon virus. Sometimes a dermatitis, known as erythema migrans or gyrate erythema, often seen with Lyme disease, this can be associated with the lone star tick as well, and it's called the Southern Tick-Associated Rash Illness. However, it has not been linked to severe symptoms, such as those of Lyme disease. So the American dog tick, also known as the wood tick, the American dog tick gets its name from the fact that the adult ticks prefer to feed on domestic dogs, although occasionally they will take a nick out of a human vessel as well. It's a member of the hard shield or hard tick family, meaning that it possesses a hard exterior shield. It is known to harbor diseases associated with Rocky Mountain spotted fever, which is spread when they suck the blood from the host. And then finally, the black-legged deer tick, Ioxides scapularis. It's a notorious biting arachnoid named for its dark legs. So they're sometimes called deer ticks because their preferred host is the white-tailed deer. It is known to transmit Lyme's disease, which is the most significant, causing Lyme's-like illness, as well as relapsing fever. So now on to management. So regarding the black-legged deer ticks, most do not carry disease, and those who do typically need to feed for an average of 36 to 48 hours before they can transmit the bacteria. And the chances of contracting Lyme's disease or any other tick-borne illness are reduced if you remove the tick using the proper techniques within the first 24 hours of the bite. And so the best way to do that is to remove the tick found attached with the human skin, or whether it's on a pet, grasping with a pair of tweezers as close to the skin as possible. Pull firmly but gently backwards. So there's a video as well to show the removal. I don't know if it'll play, but once the tick is removed with a pair of tweezers, it's also noted that you're probably going to want to use pointy tweezers, because the blunt tweezers here can risk not removing all of it. So, but basically you're going to gently pull backwards until the tick pulls free. Do not want to touch the tick once it's removed, and save it in rubbing alcohol for later identification. So some antibiotic recommendations for common Lyme presentations. For prophylaxis, doxycycline 200 milligrams as a single dose. This is for high-risk tick bites, which includes Ioxides species, Lyme endemic areas, and where a tick was attached for at least 36 hours. Treatment is recommended within 72 hours of the tick removal, and for children, adjusting for the appropriate dose. If the individual has a cutaneous rash, such as erythema migrans, either doxycycline 100 milligrams twice a day for 10 days, or amoxicillin or ceftriaxone. Azithromycin only when patients are unable to take doxy or a beta-lactam. So finally, is there any role of dermoscopy identification deer ticks? And the answer is yes. So this is an article that was published in one of the dermatologic journals. It's called The Anal Groove Sign, and a deer has been noted that the anus located anteriorly as opposed to posteriorly. So this is something that you can see with the dermatoscope. So I just want to thank everyone for your attention. I'd be happy to take any questions as well, but thank you.
Thank you, Cameron. That's very interesting and also very relevant in the state of Georgia, because I think we got ticks from north to south and from coast to river. So don't see any questions in the chat yet. I have a question while we're waiting for someone. There's an interesting phenomenon that occurs in our part of the world, and we're right in the middle of that season right now. And there is some evidence that suggests that the controlled burning practices across the southern half of the state in the piney forests is part of the reason we don't see tick-borne illnesses at the same level of frequency as we do in the central and northern parts of the states. Do you have any information on that, Cameron? Or maybe I just made that up. I don't know.
No, that is interesting. Not that I came across. I mean, I think it would make sense, but no, not, that would be something interesting to look into, definitely.
Anyone else have a question for Cameron?
I have a quick question. So, we're seeing patients now, seemingly more patients with alpha-gal, and I don't know what percentage of those people recall tick bites, but that's supposed to be, right, one of those things you get from the starry tick. Have you all seen that in your practices?
What was the illness you said that you're seeing more frequently? I'm sorry.
Alpha-gal, where, people are allergic to meat.
Oh, okay.
Yeah, I mean, that's supposed to be happen after you've had tick bites. So we've seen a few of those cases, and just one more thing to add to your list of things that ticks can trigger.
Anybody in the participant gallery seen that in their practice and have any experience with that? Don't be shy.
Yeah. Just one more little thing to, who knows, one more reason to be wary of ticks.
See any comments on that? I'm laughing about the controlled burning thing because we had students, MCG students from the class of 28 visiting South Georgia this weekend and about 2 weeks ago, and every single one of them commented on the fact they thought that the woods were all on fire and that there had to be some kind of emergency going on. I was like, no, it's just burning season. Everybody burns stuff down here. So, and I burned the woods around my house last night. So, all right. Well, very good. Well, let's see. We also can go back, and certainly if there are any questions either for Cameron or for Dr. Copeland, please put them in the chat. You see that Brenda has already included the CME stuff there. I'm going to say thank you. And at this point, I'm going to turn it back over to Brenda to close us out.
Thank you so much, Dr. Parent. Thank you, Liz, Harold, Dr. Renee, for helping us today. Thank you to all our participants for attending today. Remember to follow the instructions in the chat to claim your CME credits. You will receive as well a follow-up email tomorrow with some instructions. We will be sending during the following weeks the reminder for our next session. We're still checking if we will have on the April 7th or April 14th. We will let you know as soon as we define this. And we will have Dr. Caitlin Blanchard on Lex ulcer management. So please stay tuned for our next session. Thank you, everybody.